wasn't sure where we were going to end up in lecture, what we were going to get through. And even if we got through this in lecture, I'm still going to start with this just because how our blood picks up and transports carbon dioxide has a huge effect on the respiratory system and the entire body. So a little refresher that carbon dioxide, when we breathe it in, will mix with water in our body and form something known as carbonic acid. Now, it doesn't like to hang out as carbonic acid. Instead, it right away breaks apart or dissociates. It breaks apart into hydrogen ions and bicarbonate ions. And it's these bicarbonate ions that get transported around in the red blood cells. The problem is you do have these hydrogen ions. Hydrogen ions increase the acidic nature of blood. So the more carbon dioxide in the body, the more hydrogen ions, the more acidic it is. And we do not want our blood acidic. Our blood has that very, very narrow range that it has to stay in, that 7.35 to 7.45. So if too much carbon dioxide gets in the blood, it increases the hydrogen ions, which increases how acidic it is. Now on the pH scale, when something becomes acidic, it lowers. And so you're going to see that 7.35 go lower than 7.35. And it has to stay in that narrow range or it starts to damage various tissues. Now, it's reversible, and I'm like, because yes, we breathe in, well, we do breathe in some carbon dioxide, but our body itself is making carbon dioxide the whole time. This is why you're breathing it out. And all that carbon dioxide we are making gets stored in our red blood cells and bicarbonate ions, but it has to be reversible as well because we do need to at some point breathe out that carbon dioxide. We don't want too much carbon dioxide. Our body is making carbon dioxide and we need to get rid of it. So although it can be bound up as a bicarbonate ion, it has to be reversible using the enzyme carbonic anhydrase. It's an enzyme, enzynase. And I'm like, so that when those blood cells, those red blood cells get to the lungs, where we're going to breathe things out, it can go in reverse. That carbon dioxide goes into the alveoli of the lungs and then breathed out. So, and I'm like, just looking in your systemic capillaries. So these are the capillaries in your body systems where you're going to have a lot of carbon dioxide made. And I'm like, that's the idea, is you are bringing oxygen to various body systems and you are picking up carbon dioxide. All of that carbon dioxide that it goes through this whole chemical reaction into that bicarbonate ion gets picked up from the red blood cells, and then I'm like, it can hang out even in plasma. The bicarbonate ion can hang out in the plasma, and eventually it will make it to its lungs to get breathed out. In the pulmonary capillaries, we're in the lungs, all of that bicarbonate ion is going to move back into the red blood cells from the plasma. It combined with the hydrogen ion, form that carbonic acid, splits, and goes right back into that CO2. It essentially, once the blood gets to the lungs, bicarbonate ion goes into the red blood cells, picks up a hydrogen, makes carbonic acid, breaks apart into carbon dioxide to get breathed out, as water is a byproduct. We want this constantly going back and forth, pretty much just always trying to store all of our carbon dioxide as this bicarbonate ion. There's very little CO2 in your body. You'd be very gassy. And Mike, so there's very little CO2 just floating around as a gas by itself. It's always transported and kind of hangs out as this bicarbonate ion. And I'm like, so when your cells make carbon dioxide, all that carbon dioxide gets switched over to bicarbonate ion, and when we want to get rid of carbon dioxide out of the body, it reverses so that we can breathe that carbon dioxide out at the lungs. This is showing some of that. This is your tissues. They're generating lots of carbon dioxide. Carbon dioxide will go into your red blood cells. They bind up with water. They make the carbonic acid, and we now have that carbonic or bicarbonate ion, as well as some hydrogen, that acid. In reverse, and I'm like, which we'll get into the reverse, is when it gets to the lung tissue, and I'm like, where we want to drop off carbon dioxide. Right now, just at the tissue level, we're picking up carbon dioxide. Now, the amount of carbon dioxide that can be transported is affected by how much oxygen, pressure of oxygen, is present. It's known as the Haldane effect. The idea is if there's less oxygen present, the more carbon dioxide the blood can pick up. It's almost one of those, the hemoglobin can only carry so much. And I'm like, if you don't have a lot of oxygen, you can carry a lot of carbon dioxide and vice versa. And so when we have something known as reduced hemoglobin, and I'm like, which means it's not full of oxygen. It doesn't have as much oxygen as it could carry. Instead, it will pick up carbon dioxide and form something known as carboaminohemoglobin. It's pretty much carbon dioxide attached to hemoglobin. So if there's less oxygen present, our hemoglobin's more likely to pick up CO2. And then the reverse, now like that in the tissues, when it, and I'm like, when it's picking up the carbon dioxide, sorry, not in reverse yet. And I'm like, it encourages exchange in tissues. So when it drops off oxygen, it will pick up CO2. But then in reverse, as it goes to the lung and it gets rid of CO2, well, that's what we want our red blood cells in the lungs to do, is when we get rid of CO2, we want those red bloods to pick up the oxygen. So it can go in reverse as well. So this is showing them like when these red blood cells get to the lung tissue, there's your alveolus. And I'm like, all of that bicarbonate ion will mix with hydrogen ions, form your carbonic acid, and then break apart, and that CO2 is going to go into the lung tissue, and you breathe it out. You're breathing it out right now. This is all happening right now in your bodies. Now, what's nice is because it can kind of go back and forth in this equation, we have this bicarbonate buffer, that HCO3, that resists changes in blood pH. We want our blood to have this really narrow pH, and it allows our body to adjust to any type of change in pH. So if hydrogen ion in our blood starts to rise, that means it's becoming acidic. Some of that excess of hydrogen ions can combine with HCO3, the HCO3, the bicarbonate buffer that's holding the CO2, and it becomes this carbonic acid. It just is binding up excessive hydrogen ions. And although it's called carbonic acid, it is an acidic molecule, but it really only has an acidic ability, and I'm like, when it breaks apart and releases the hydrogen ions. As is, just sitting there, the hydrogens are bound up right there, and they're not doing any damage. It's only when those hydrogen ions are released that we do that damage. So if there's excess hydrogen ions present, we can bind it up and form the carbonic acid. And then vice versa, if the hydrogen ions begin to drop, which now you're becoming more alkaline instead of acidic, we can break apart the carbonic acid. We can release some of those hydrogen ions and start to make it more acidic and get it back into that narrow range. So I'm like, because we can move things back and forth, I'm going to go back to that little thing. Because we can pick up hydrogen ions and store them in this carbonic acid, or if we need hydrogen ions, we can break this apart and release hydrogen ions. Because we can keep going back and forth, and I'm like picking up and releasing hydrogen ions, we can really try to keep our blood in a very narrow range. Now, things that can influence the amount of carbon dioxide, how do I say, I'm like the amount, how carbon dioxide influences your blood pH. It all comes down to that hydrogen ion that's released. Now, when you have really slow, shallow breathing, you're going to increase how much carbon dioxide is in your blood. And based on that equation, the more carbon dioxide, the more hydrogen ions, the more acidic, which is a drop in pH, because acid is low on the pH scale. So slow, shallow breathing can cause your blood to become acidic, versus rapid, deep breathing. So really deep breaths, big, huge, deep breaths in very quickly, big, huge, deep breaths out very quickly, can actually decrease how much carbon dioxide is in the blood in reverse. And I'm like, you're going to essentially get rid of hydrogen ions, and your blood can become alkaline or rise in pH. So a change in your breathing can change your blood pH. This is one of the, major reasons for people that are going into respiratory therapy and all the people that are going into nursing. your breathing rate has such a huge effect on your blood pH. And I'm like, it is the most, most important thing that changes or can change your blood pH. Just by changing your breathing, you can change your blood pH. Now, other than the fact that we can change our breathing to change pH, there are other things that can control our respiration, not just our breathing rates. And our brain is essentially controlling our respiration. And there are higher brain centers, there's lots of chemicals or chemoreceptors, and there's reflexes that control your breathing, your respiration. We're going to look at a couple of the neural controls first. And two of the big areas in your brain that are controlling your breathing, how many times you breathe in and out every minute, are the medulla and the pons. Again, the medulla is really important. If you damage it, it's deadly because of the things that medulla oblongata controls. And breathing is one of them. Now, in the medulla, we have neurons. We have them grouped in two separate little groups. We have a ventral respiratory group and a dorsal respiratory group in the front and in the back of the medulla. And the ventral respiratory group, the front one, this is the one that sets your normal breathing and rhythm. The fact that you are sitting there and just sitting there, you're taking about 12 to 15 breaths per minute, whether you realized it or not. That's the ventral respiratory group of your medulla oblongata that's controlling that. How it controls that? It excites inspiratory muscles, so muscles involved in inspiration, in the phrenic nerve, which controls your diaphragm, and your intercostal nerves, which control the external intercostal muscles. When you excite those and you cause those muscles to contract, it causes you to breathe in. When you don't excite them and they relax, you breathe out. And so it's setting the rhythm by controlling those two areas that's going to cause you to breathe in. Now, this is just showing, just so you've got, a picture of the front. And here's the medulla oblongata. There's that big expanded pons area. There's the ventral, and it's controlling the diaphragm and your external intercostal muscles. The dorsal respiratory group, so at the back of the medulla oblongata, it receives information from peripheral stretch, just the fact that you've got muscles stretching even in your lungs. It's receiving information from that. It's receiving information from chemoreceptors, including carbon dioxide, oxygen input, and it sends information to the ventral. So it's just receiving information and it's just relaying it to the ventral. Part of it is that the ventral might need to change how many breaths per minute you're taking. How exactly the dorsal respiratory group works, there's still a lot of unknowns in there. We know it's receiving information, we know it's sending to the ventral, but we're not completely sure of all the steps in there. And then the other part of your brain stem that's controlling your respiration is the pons. We call it the pontine respiratory center. It's because it's the pons. It's this expanded region, and it's the part of the brain that's just smoothing out the transition between breathing in and breathing out, inspiration and expiration, and vice versa. So it's sending messages to the ventral respiratory group as well as the dorsal, which just sends more information to the ventral, to modify your breathing. It can fine-tune it. And so you don't have rapid, sharp stops when you're breathing out and rapid, sharp intakes when you're trying to breathe in. It can set or change your rhythm when you're talking. It can change the rhythm of your breathing when you're sleeping, when you're exercising. So it's modifying. So the ventral really is setting the rhythm. The pons is really helping make it flow better as well as changing it when needed. Now, the chemical factors that can affect your breathing. Most important chemical factor that affects your breathing is that carbon dioxide. It's the most potent, it's the most closely controlled. Now, our pressure of carbon dioxide in our blood is about 40 millimeters of mercury pressure, and it has to be maintained at that. It can maybe change, plus or minus 3 millimeters of mercury, but it has to stay in that very narrow range. If the blood carbon dioxide levels rise, you're going to have too much carbon dioxide in the body, in the brain. It can, when it mixes with water there, it becomes hydrated. It makes that carbonic acid, which breaks apart, releasing the hydrogen ions, and you now have an acidic brain. That's not good. Now, that acid, those hydrogen ions, will stimulate chemoreceptors at the brainstem to try to change your breathing. And I'm like, so that we don't have acid on the brain. And so all of that acid, those excessive hydrogen ions, and I'm like, will tell your respiratory system we need to increase the depth and rate of breathing, which breathes out carbon dioxide. And I'm like, and if we breathe out carbon dioxide, we're breathing out acid, the hydrogen ions, and your pH can go back up. It's no longer acidic. And so the carbon dioxide, the fact that it can become acidic when it goes through that process and release hydrogen ions, is the big, huge stimulator controlling your breathing, making you want to breathe in. Now, when someone hyperventilates, that's an increase in depth and rate of breathing that actually removes too much carbon dioxide from the body. And if you remove too much carbon dioxide from the body, you'll have decreased blood carbon dioxide levels, and it can cause you to become dizzy or fainting. This can happen if you've ever tried to blow up a balloon and you're doing these big, deep breaths, trying to push all of that air out. You're actually removing too much carbon dioxide, and it's why you get dizzy when you blow up a balloon, is because of that low carbon dioxide level. Now, if you breathe it out enough, which probably wouldn't happen, dizziness usually stops you and fainting usually stops you. But if your levels of carbon dioxide go low enough, it could cause breathing to stop altogether. That usually happens some other types of respiratory issues going on. You, if you're blowing up a balloon and you don't realize you're dizzy and don't stop, would probably faint, and then everything would reset itself. Now, oxygen does have some influence on our breathing. Everyone's like, well, yeah, I have to breathe. I need oxygen. Although oxygen doesn't, it takes a little more for oxygen to change, for you to change your breathing. Your breathing generally changes because of carbon dioxide, not because of oxygen. So we do have chemoreceptors in our aortic, in our carotid bodies, which are found in the carotid arteries in your neck, and they're always detecting oxygen levels. We need oxygen in a lot of important areas in our body, including up in the brain. Now, when they get excited, because our low oxygen levels, it can cause our respiratory system to increase ventilation, meaning we need more oxygen. And I'm like, however, low oxygen levels normally only have a slight effect on ventilation. And so when your oxygen levels go down, they actually have to go down quite a bit. They usually have to drop down to 60 millimeters of mercury, and they normally sit at around 100. That's a huge drop. When it came to carbon dioxide, it started to have an effect when it only changed maybe, more than 3 millimeters of mercury. This has to have a huge change of less than 40 millimeters of mercury for your oxygen levels. And part of that is your hemoglobin has a huge oxygen reservoir. So even though your pressure of oxygen is going down, you still have a lot of oxygen available. So it requires that substantial drop to stimulate ventilation or your breathing to change. No, and I'm like, it's another chemical that can affect our breathing is that pH. And again, we've already kind of talked about that and how pH changes with breathing. Because I'm like, the pH can change our breathing if carbon dioxide or oxygen levels aren't normal. And it's usually the decrease in pH that's going to cause the biggest breathing change. Part of that is, I'm like, things that can cause you to have a low pH. If you have too much carbon dioxide in your body, accumulation of lactic acid. You had a lot of running, you didn't, I was going to say, I'm like, and you didn't get enough oxygen to your muscles that they had to work in an anaerobic state and they made lactic acid. Or if you have an excess of ketone bodies, which can happen if you're having some type of liver issue. But either way, and I'm like, if you have a decrease in pH, your respiratory system is going to change the breathing. You're going to increase your respiratory rate, increase the respiratory depth. I'm like, so that we can raise the pH. And so your pH levels affect your breathing. Now, just a summary of the different chemicals. The most important chemical that affects your breathing, carbon dioxide. When your blood pressure, your oxygen pressure falls below 60 millimeters of mercury, then it becomes a major stimulus for respiration, but it does require a big change in pressure of oxygen. And anytime you have a change in your blood pH, especially in your arteries, it usually results some too much carbon dioxide or some other metabolic factors that indirectly trigger some of our chemoreceptors. And I'm like, but either way, these are things that are gonna cause your breathing to change. Now, other than the fact that we have chemicals that can cause you to change, and I'm like, big thing, the carbon dioxide, the oxygen, there are other types of chemicals that can cause it. pH can cause your breathing to change. We do have higher brain centers. There's some other things that can make some modifications to your breathing. One is the hypothalamic control. Now, the limbic center, the limbic system of our hypothalamus modifies the rate and depth of respiration. And the limbic center, if you remember, is part of our emotional response. And so our emotions can change our breathing. An example is if all of a sudden your breathing changes or you hold your breath because you're so mad or you're gasping in pain. And I'm like, that's a change in respiration. If you have a rise in your body temperature, that's going to increase your respiration. That can also happen in reverse. If you've ever done something like the polar plunge and you're so cold you stop breathing, and I'm like, that can happen too. Your cerebral motor cortex, this is your conscious thinking, the fact that you are thinking through things, that's your cerebral motor cortex. We can bypass the medullary controls. If you wanted to hold your breath right now while you're listening to that, you can do that. That's a higher level thinking. You can cause you to hold your breath. However, at some point, your blood carbon dioxide levels are going to increase because you're not breathing that carbon dioxide out, and your brain stem is going to override your cerebral motor cortex, and you're going to start to breathe again, which is why at some point you can't hold your breath forever. And people sometimes can hold their breath long enough to make themselves pass out. And pretty much it's your body's way of overriding your motor cortex, the conscious thinking, so that it can then start to do its own thing to get that carbon dioxide out. Other things that can kind of change or modify your respiration are any types of irritants that get in there, that you breathed in some dust or pollen, whatever. If there's anything in your respiratory system that can change your breathing. Mostly it's, we can constrict the air passage, so we can constrict, at least the air passages that are having that irritant, that dust, that smoke, the pollen, whatever it is. Depending on where it is in our pulmonary tract, we can cough if it's in the trachea or in the bronchi. If it's just an irritant way up in the nasal cavity, it can cause us to sneeze. But it changes our respiration. Another thing is called the Hering-Breuer Reflex. It's an inflation reflex. Our lungs can only get so big. And so we have stretch receptors in our lungs, in the pleura of our lungs and in our airways, that as they stretch, when our lungs become inflamed, those signals tell our brain, the medulla, to end inhalation and allow breathing out or expiration. It acts as a protective response so that it protects the lungs from being overly or excessively stretched. That our lungs can only get so big, and then it tells our brain, okay, we need to stop breathing in and we need to start breathing out. Now, some other adjustments is if you exercise. So your respiratory system has to adjust to both the intensity of your exercise and how long you're exercising. And your increased ventilation can easily go up 10 to 20 fold. You're breathing right now 10 to 15 breaths per minute. That can, increase by 10-fold. You can have 100 and some breaths per minute. And or you can be increasing how much oxygen or how much air is actually going through your lungs every single minute. The interesting part, is the pressure of your carbon dioxide, pressure of your oxygen, and your pH remain surprisingly constant during exercise. And that is because of that increased ventilation, that we get the oxygen in, we get that carbon dioxide out. And so we maintain our blood pH the whole time. Now, exercise, yes, can change our breathing, but there are 3 factors that right away are going to cause you to increase breathing. First one is psychological stimuli. if you know you're going to start working out, you know you're going to go for a run, you know you're going to go for a bike ride or whatever it is, the anticipation of exercising without even doing anything yet, the anticipation of exercise will actually trigger you to start breathing faster. So I'm like, next time, try to pay attention. You'll see. The stimulation of our skeletal muscles and our respiratory centers. And I'm like, is going to cause you to start breathing faster. Your skeletal muscles are working. They're generating heat. And I'm like, they are triggering the respiratory centers to increase that oxygen consumption and to get rid of the carbon dioxide that's being produced. And then we have excitatory impulses to the respiratory centers from your little receptors in your moving muscles, receptors in your tendons, receptors in your joints. There are little receptors monitoring your body, and if it's moving, it sends information to the respiratory system. Well, we're moving, so we're probably going to need more oxygen, and we're going to need to get rid of carbon dioxide so that inspiration or that ventilation increases. Now, my note on this, ventilation, your breathing rate, declines suddenly as exercise ends because all three of those neural factors are shut off. You're not anticipating exercise anymore. You're not moving your skeletal muscles. You're not moving those tendons. You're not moving those joints. And that increase in ventilation goes down, and it goes down extremely quickly. It's one of the biggest reasons why they say when you're done exercising, you just got done running a 5K, don't cross the finish line and stop. You have to keep moving, even if it's walking slowly. Even if you're walking slowly, you're still activating your skeletal muscles, you're still moving muscles, tendons, and joints, and so your respiration can stay up, because even though you cross the finish line, your oxygen consumption is still at an increased need, and your carbon dioxide levels at an increased need to get rid of. So I'm like, don't ever just cross the finish line and stop. Just keep moving, even if it's slowly. And eventually our respiration rate will get back to a baseline because we've gotten rid of the carbon dioxide out. We've breathed it out after we've exercised. Now, it does happen that some exercise will lead to anaerobic respiration. For whatever reason, you didn't get enough oxygen, and now you're going to have lactic acid being produced. It's usually not because your respiratory system isn't working correctly. Sometimes it's because your heart isn't pumping enough oxygenated blood to the skeletal muscles that are needed. And sometimes it's the skeletal muscles' inability to increase their oxygen uptake. They don't have enough mitochondria in their cells because you haven't worked out enough yet. And I'm like, or even that skeletal muscle that's working really hard can constrict on those blood vessels, prohibiting that oxygenated blood getting to the muscles where it's needed the most. Either way, there's times that, yes, your exercise can go anaerobic, not because of poor respiratory system, but because of other things going on. Usually because people are out of shape or you're working muscles beyond what they're used to, meaning they can't increase the oxygen uptake yet. Your high altitudes can also affect your respiratory system. If anyone's ever traveled to high altitudes, they usually say at least 800 feet above sea level, it can experience something known as acute mountain sickness. It's because the atmospheric pressure and the pressure of oxygen levels are lower. There's less oxygen around. Symptoms of this: headaches, shortness of breath, nausea, dizziness. In severe cases, it can lead to lethal cerebral or pulmonary edema, fluid on the lungs, fluid on the brain. That's pretty rare. You just have to go, an extreme change in altitude. But this is why people that climb mountains, they have to adjust to these different high altitudes. And I'm like, they have to adjust, which gets into our adjustment. And I'm like, but they have to adjust, otherwise the body can't handle those low oxygen levels. And so after a while, if you're at those higher elevations, our body becomes acclimated. As your respiratory system starts to change the breathing rate, and your hematopoietic adjustments happen, aka your red blood cells start to adjust as well. Now our chemoreceptors are going to become even more responsive to your pressure of carbon dioxide when the pressure of oxygen declines. And so you might not even need an even smaller change in carbon dioxide levels to change your breathing. And so shortly, usually within a couple days, your minute ventilation increases, meaning how much air goes in and out in a minute. and it stabilizes usually about 2 to 3 liters every minute higher than at sea level, which means you have 2 to 3 liters of air going in and out of the body every single minute. And I'm like, you've increased your breathing rate, you've increased your breathing depth to get the oxygen that you need. Now, even at a high altitude, you're always going to have a lower than normal hemoglobin saturation of oxygen. There's just less oxygen available. And I'm like, they usually say at higher levels, at high altitudes, usually have about 65 to 70% saturation level. And I'm like, we're at sea level, it's closer to a 98% saturation. Now that decline in blood oxygen is going to stimulate your kidneys to produce that erythropoietin, the hormone that's going to make you to have more red blood cells. So your red blood cell numbers are going to increase so that the oxygen that is available is going to get picked up and transported. So people that live in higher altitudes have more red blood cells in their blood. If you ever go and work somewhere that has a higher altitude, it's a very noticeable difference when you draw blood. It's a really dark, it's almost a brownish color even. I'm like, but it's a really, really dark red. And I'm like, not a nice, pretty bright red, like a really dark red. They have more red blood cells. They need them. They need more red blood cells to pick up the available oxygen because there's less available oxygen around. Now, some problems that can happen with our respiratory system. COPD, or chronic obstructive pulmonary disease. I see this in a lot of commercials. There's lots of drugs out there to try to help. The only problem is it helps. They don't fix. And I'm like, it's an obstructive disease. It's exemplified by bronchitis and emphysema. And I say chronic bronchitis. This is not one you just picked up a viral or bacteria infection, you got bronchitis. This is like long-term bronchitis. And I'm like, it's important to know these different terms, these different imbalances, like what is COPD, what is bronchitis, what's emphysema. It's because COPD really is a combination of having both chronic bronchitis and emphysema. And it's an irreversible decrease in the ability to force air out of the lungs. And again, if you can't get air out of the lungs, you can't get rid of that carbon dioxide. And if you can't push that carbon dioxide out and get air out of the lungs, and I'm like, you're not breathing in fresh, new, oxygenated air. And so I'm like, it's in, we just can't force out the air out of the lungs. Now, common features of people, and I'm like, that have COPD, there's usually a history of smoking. And I'm like, not everyone though. There's usually some type of labored breathing called air hunger, and it gets worse and worse every year. There's usually more coughing, more frequent lung infections, and at some point they're usually going to develop respiratory failure. It's known as hypoventilation. It means they're going to retain that carbon dioxide in their body. And if you retain carbon dioxide, you now have additional hydrogen ions, and you have what's known as respiratory acidosis. You have too much, your body's becoming acidic because you can't get rid of that carbon dioxide. You can also experience something known as hypoxemia. It means low levels of oxygen. Again, you can't breathe out that carbon dioxide, and if you can't breathe out the air, you can't breathe in that oxygen. So I'm like, it's just this whole part of our respiratory system that's damaged, that's affecting breathing. Now, again, it's a lot of times affected or influenced by people that have emphysema. Now, emphysema is an enlargement of the alveoli. It's because it destroys the alveolar walls. This is normal lung tissue, lots and lots of alveoli, which means you have lots of surface area for gas exchange. If the alveoli become enlarged, it's because all of these walls were damaged. You have less walls, less gas exchange. You also have less lung elasticity. It can't stretch as well anymore. It might start to tear. And usually the accessory you're going to need accessory muscles for breathing. You can't just use your diaphragm and your external intercostals. You now have to think about it. You have to try to, almost puff up your lungs even more. You have to think about breathing, about getting those nice deep breaths in, which causes you to become exhausted. And I'm like, you are physically exhausted. You are making muscles work that just shouldn't and don't need to be working. And people become extremely exhausted by it. Now, some people experience emphysema or get emphysema, and it's a slow condition. It just doesn't, wake up one day and this happens. Usually caused by smoking, that damage to the lung tissue. However, there are cases that it's genetically driven as well. Most of the times it's caused by smoking. Now, the other thing that can aggravate that COPD is chronic bronchitis, is inhaled irritants. Yes, it could be from smoking as well, but any type of inhaled irritants is going to cause a chronic excessive mucus production, and that excessive mucus becomes inflamed, and it causes almost a fibrous or scar tissue to form in the lower respiratory passageways, which can cause obstruction of the airways. And if you have obstruction of the airways, you have impaired lung ventilation and gas exchange. You're not getting the air in that's needed. You're not getting the air out that's needed. And it's also, going to cause you to have more frequent pulmonary or lung infections because you're not doing what it's supposed to be doing. You're supposed to be able to trap irritants and catch them in mucus and just easily with those ciliated cells get rid of anything that's trying to get in the body. And if you don't do that, you're going to increase your chance of lung infections. Now, smoking is a major risk factor for chronic bronchitis, but even environmental pollution. If you live in those big cities with the smog, and that's a constant inhaled irritant that they're dealing with. Now, COPD symptoms and treatment. There's usually one of two ways that people go with COPD. It depends on their innate respiratory drive, what they're born with. You don't control it, but your body's going to do one of two things with COPD. And one group of individuals are nicknamed the pink puffers. It means their body is trying to work so hard to try to get that carbon dioxide out and oxygen in. They are working really hard, using all those additional muscles. They're usually very thin individuals, and they have near normal blood gases. It means they're working really hard to stay normal. And then there's an opposite, what we call as blue bloaters, that their systems aren't working as hard, and they start to turn a little blue because they're hypoxic. They're having lower oxygen levels, and they're usually a little more of a stockier build. And they're not using those excessive muscles. They're not getting the oxygen that's needed. Now, we can treat it with bronchodilators, things to open up those airways. Usually some type of inhaled corticosteroid. Again, usually try to open up some of those airways. They're usually given oxygen tanks so that whatever you are breathing in is a higher level of oxygen. Sometimes they do surgery and reduce lung tissue so that the remaining lung tissue that's there, maybe it's the better lung tissue, has more room to expand when you do breathe in. And unfortunately, normal COPD, it's treated. I would never say it's gone. And they're doing things to try to help you get the oxygen in and the carbon dioxide out, but it's a forever condition. Now, these are just some things, how we get COPD. Yes, tobacco smoke, air pollution are two environmental things that can cause you to have bronchitis and emphysema. Emphysema can be genetic. There is a genetic deficiency. But either way, these two things are going to cause you to have difficult breathing, frequent infection, airway obstruction, air trapping, leading to respiratory acidosis, low oxygen levels, and low breathing rates. None of it good, but that's when we consider someone as having COPD. Now, if anyone ever suffers from asthma, they call it reversible COPD. It's like all those things of COPD, but it's not a long-lasting chronic issue. It can go away. And so it's usually characterized by coughing, difficulty breathing, wheezing, chest tightness, any of these by themselves or all of them together in combination. But either way, it's going to be some type of inflammation of the airway. And that it gets smaller. We have bronchospasms, that the bronchial tubes are constricting on themselves. Now, airway inflammation itself is an immune response, and for some reason our immune system can cause you to have asthma-type symptoms. And whether it's, our body is saying that there's just something that we don't want in our body, or, a response to something else that you're having some type of immune reaction to. Usually the treatment for asthma is some type of steroids, like epinephrine, to try to dilate the bronchioles, pretty much get them open so that we can get the air in that's needed. Another issue that can happen in your lungs is tuberculosis, or TB. It's a bacterial infection, and it enters through inhaled air, and it usually affects just the lungs. Symptoms: fevers, night sweats, weight loss, a racking cough, whole body shakes when you're coughing, and it's usually mucus that comes up and it's tinged with blood. Now, they usually say about a third of the world has this particular bacteria, but most people's immune system keeps this bacteria under control and in its own little compartments or tubercles in the lung tissue. People that have weaker immune systems can't fight it then. Can't, keep these bacteria in their own little tubercles in the lungs, and it ends up with a lot more symptoms. Now, the problem with this bacteria, it's hard to kill. It's not just, a 10 to 14 day dose of antibiotics. You're taking antibiotics for a good year, and the unfortunate part is a lot of these strains of Mycobacterium tuberculosis are becoming resistant to antibiotics, making them even harder to treat. Lung cancer is the leading cause of cancer deaths in North America. Most of them are caused by smoking, so it is a largely preventable cancer. The earlier you can detect it, the more likely it is that you're going to have a good outcome. If there is no metastasis or no moving from its original source in the lungs, they usually just go in and surgically remove one of the diseased lung tissue. They can remove easily a full lobe of a lung. If it has metastasized or is now traveling from the lungs, then radiation and chemotherapy is now needed. And unfortunately, they usually have really low success rates. And like lung cancer that is traveling outside the lungs has a really low success rate. They are looking at some alternate types of treatments, and it's usually things to try to boost your immune system so your immune system can fight the cancer. Another, it's my last imbalance issue that can happen with the lungs, is a condition known as cystic fibrosis. It's a genetic disease. It means 1 in every 2,400 births end up picking up the gene for this particular disease. And what ends up happening is that you get a really thick mucus that clogs the passageways of your airways. And that mucus, it's a warm, moist environment, and it is huge for bacterial infections to occur. Now, the gene is, you've got damage to a gene that's genetic for chloride membrane channels. Pretty much just means that you have less chloride ions secreted into your mucus, and if you have less ions, you have less water, and that's where you get this thick mucus. It's common to have mucus in your airways. It's there to trap. And but if you have a really thick mucus, it traps too much bacteria, and it's too thick for our cilia and our coughing to get rid of. And so it traps bacteria, and it becomes a perfect breeding ground. And so treatments for cystic fibrosis are usually some type of drug to thin or dissolve the mucus, or even to manipulate that mucus in there to kind of loosen so it can be coughed up. So it's a lot of time almost like this vibrating, shaking of the body to just loosen up the mucus so it can be coughed out. And a lot of individuals are even put on a low dose of antibiotics to try to keep those bacteria at bay. Now, some developmental aspects of our respiratory system. It's mostly as you are developing, as a fetus is developing, the upper respiratory system or upper respiratory structures of your respiratory system develop first. It kind of starts with the nose and works its way down. And so by the 4th week, before you might even know you're pregnant, and already we have what are known as olfactory placoids. It's little holes that will eventually go inward and become your olfactory pits of your nasal cavity. I'm going to show the picture. So by the 4th week, we already have little, indents. Even by the 5th week, a week later, we're already starting to develop what's known as the laryngotracheal bud. And where the trachea is starting to bud into 2 buds, because you're going to have 2 lungs there. So by 5 weeks, you're already developing various parts of the respiratory system. By 8 week, we can already start to see some of the bronchial tubes and even some of the alveoli. By the 28th week, a premature baby can breathe on its own. And that's the 7 months. That's what every pregnant woman wants to get to, at least hit 7 months. If you are born before 28 weeks. Usually the biggest issue with infants is they suffer from something known as the infant respiratory distress syndrome. It's because the fetus, before it hits 28 weeks, hasn't made a substance called surfactant. And surfactant reduces surface tension. And this is where we get into possibilities of lung collapse. And I'm like, if the infant doesn't have that surfactant, it can't reduce the surface tension. The lung tissue doesn't want to expand because that, as I say, it's almost like the water wants to stick to water, and it will constantly try to cause lung collapse. Now, that doesn't mean every infant that's born before 28 weeks dies. And I'm like, it's because there's things we can do to help. And I'm like, we can actually spray in artificial surfactant into infants' lungs. And I'm like, in the NICU. Problem is, there's usually premature babies before 28 weeks are usually going to have some type of respiratory issues. Just means their respiratory systems, they didn't develop normally on their own. And so infants born before 28 weeks usually have, they suffer from asthma, or they suffer from some other types of lung distress. Now, during the fetal life, the lungs are filled with fluid, and all the blood bypasses the lungs because they're not breathing oxygen. And I'm like, all their gas exchange takes place by the placenta. They're not breathing air because they can't, because they're inside another body. And so all their gas exchange takes place in the placenta. However, at birth, all the respiratory centers become activated. The alveoli inflate, and the lungs immediately start to begin to function. By about 2 weeks after birth, the lungs are fully inflated. Now, the respiratory rate, how fast they're breathing, is the highest in newborns, and then eventually slows down. So at birth, infants look like they're hyperventilating because they can easily be taking 40 to 80 breaths per minute. We take between 12 and 18 breaths per minute, so it looks like they're hyperventilating. That's normal. And I'm like, as they get older, the lungs continue to mature, more alveoli are formed until they hit young adulthood. And then the reverse happens as you start to get older, and I'm like, the aging sucks. Your respiratory efficiency starts to go down, your lung volume goes down, the lungs lose elasticity, and your blood oxygen levels will start to decline. And I'm like, it also leads you to develop something known as sleep apnea as well. So I'm like, yay, we can develop everything, but everything goes in reverse as we get older. Now, the review questions. Even the most forceful exhalation leaves air in the lungs. This is called residual volume and is needed to keep the alveoli patent or open. And I'm like, we can't breathe out everything. Even though you tried to breathe out everything, you can't breathe out everything or your lungs would collapse. There are two gases that contribute to 99% of the total atmospheric pressure. It's nitrogen and oxygen, not carbon dioxide. The majority of what you are breathing in and out right now is nitrogen, followed by oxygen. And I'm like, that 1% is where you get carbon dioxide and some other gases. The pressure exerted by each gas in a mixture, like what you're breathing in, is proportional to its percentage. That law is known as Dalton's law of partial pressures. Hemoglobin molecules are fully saturated when they are bound to 4 different molecules of oxygen. Red blood cells contain the enzyme this, which helps make carbonic acid. That's the carbonic anhydrase. This is responsible for setting the basic breathing rhythm. That's the ventral respiratory group. The most potent chemical influence in respiration is carbon dioxide. Those levels have to really be maintained the same. And then this is produced by the what in response to low oxygen levels. Erythropoietin is produced by your kidneys in response to low oxygen levels, like when you go to higher elevations. And the loss of lung elasticity and destruction of alveolar walls, that's your emphysema, where you have less surface area because you've destroyed all the alveoli walls itself.